Okay, good afternoon, everyone. This is Tony Trahan with the New York State Office of Mental Health. I want to thank everyone for coming today for this webinar on MyPSYCKES. A brief orientation to webinars for people who haven't attended before. Due to the number of people that we have attending, we do have to keep the lines muted, but please feel free to ask questions via the chat function on the webinar control panel. You can put in questions anytime and I will be monitoring them. And then at approximately 2:15 or 2:20, we will stop and we will ask and we will do the question and answer period with our presenter today. During the webinar, you may experience some momentary lapses in the audio, but this is normal and it should not interfere dramatically with the content. This webinar is being recorded and archived. You will receive the link to the archived version in an email later today or tomorrow for you to share with other people in your agency. We currently have approximately 60 people on the webinar right now, and that when the webinar ends, you will receive a short survey. So a window will open up, and there will be a survey on there with about 5 or 6 questions. If you could please take the time to fill that out. Everyone attending today will receive a certificate via email. If people are sharing a computer to view the webinar, please list all the people requesting the certificate, and they will all be sent as attachments to you in one email. So let's begin. I just want to let folks know that our office has been working with the MyPSYCKES team now for the last 4 years. It has been a great collaboration, and they have been very keen to hear and use what consumers have to say to guide the development of this initiative. Today we have Edith Keeley. I know that initially we were thinking Molly Finnerty was going to be our presenter, but she was called away at the last moment, and Edith has been gracious enough to join us as our presenter. Edith has been a great person to work with. She's a very good listener. She asks very poignant questions of us, and she has been very flexible and accommodating in working with us in the Office of Consumer Affairs. So without further ado, I will turn it over to you, Edith.
Thanks so much, Tony. And before I start, I would like to just acknowledge the wonderful partnership and collaboration that the PSYCKES team has enjoyed with Tony, with John Allen, with Celia Brown and Digna and many of the other recipient affairs specialists throughout the state of New York as we work together to develop and spread and implement MyPSYCKES. And it's a partnership that has really benefited the application, and it's something that we really look forward to continuing. So thanks very much, Tony, for the opportunity to present MyPSYCKES on today's webinar. What we're hoping to accomplish today is first to give you a brief sense of the history of the MyPSYCKES project, how it's developed over time, to give you a peek into the MyPSYCKES application, how we envision it working within a clinic, the types of resources and information that are available within the application, and particularly a focus on the CommonGround questionnaire that is embedded within MyPSYCKES and is a tool for shared decision-making, which we are fortunate enough to have licensed from Dr. Patricia Deegan, who many of you may know. I'll talk a little bit about our current pilots. Very exciting to actually see MyPSYCKES up and running, and do want to leave plenty of time to answer any questions that you might have about MyPSYCKES. Okay. So first of all, when we say MyPSYCKES, what exactly do we mean? And I would like to point out that even the name MyPSYCKES is the result of our collaboration with consumers. This was a name that was chosen by members of our consumer advisory group. So when we talk about MyPSYCKES, what we mean is really a computer-based set of tools. It's interactive, it's web-based, and it's really designed to support and prepare people for visits with their prescriber. This is a peer-supported project, so peer specialists are an integral part of the implementation strategy for MyPSYCKES. And really the goal is to help consumers be active participants in their treatment and recovery. Pat Deegan talks about CommonGround as a way of amplifying the consumer's voice in the clinical encounter. And that's certainly something that we hope to achieve with MyPSYCKES. There are three main components of the application: My Treatment Data, which is a portal into Medicaid data, a Learning Center, and then the CommonGround survey. As Tony mentioned, this is a project that has been underway for a number of years. We first began focus groups with consumers and families to try and understand what their information needs were, particularly around medications, as far back as 2006. We began working with Dr. Deegan soon thereafter and really started working on developing the application at about the same time. We prototyped a version of MyPSYCKES and are very grateful to our partners at the South Beach Psychiatric Center Baltic Street Clinic, who were really the first ones to kick the tires, so to speak, of the application and have been providing us great feedback on its usability. And as I mentioned, we are now piloting MyPSYCKES at 2 sites, and we'll talk more about that later on in today's presentation. The goals of MyPSYCKES, as I mentioned, really first and foremost are to support shared decision-making between physicians and recipients of mental health services. We hope that using MyPSYCKES will increase engagement and improve the health literacy of service users, and also, we hope, improve prescribing practices and really help to align the medications, the pill medicine that people are taking with consumers' recovery goals. The strategies for implementing MyPSYCKES focus on implementation for all clinic clients. We've spoken a lot with Dr. Deegan about her experience in implementing CommonGround in many states around the country, and really this doesn't work if it's just seen as something that a handful of people do. This is really about changing the way a clinic operates. And so this is something that really we recommend should be implemented for all clinic clients, all people who receive medication. The CommonGround Health Report, which again we'll be looking at in a little bit, is really a tool to improve the client and prescriber communication, to really make sure that the prescriber and the client are making the most use out of that 15-minute appointment that they can. Looking ahead, there are many ways that we think MyPSYCKES can continue to evolve to support the dialogue between doctors and clients. For example, we could develop individual messages that consumers would get when they log on to MyPSYCKES to prompt them about questions that they might want to address with their doctor, to notify them about new resources that are relevant to them. There are lots of different things that we could do, and we're very excited about moving in that direction. Okay. So I mentioned that MyPSYCKES really represents a change in the way a clinic does business. So I just wanted to give you an overview of what we mean by that, and let's all keep our fingers crossed that the animation works as planned. But really at the center of MyPSYCKES is peer support. That really is the way we see it right now. It's a core value, a core component of MyPSYCKES implementation. So that's right there at the middle. The way this works is that a consumer, a service user, comes into the clinic for their regularly scheduled medication appointment. But now they're coming in for an enhanced medication visit of 45 minutes. The first half hour of that 45-minute appointment are spent in the Decision Support Center, where the consumer sits down at a kiosk and completes the CommonGround survey. Peer specialists are available in the Decision Support Center to help the consumer with any questions or technical difficulties that they might have, to offer a welcoming environment, and to be a support to the consumer as they complete the CommonGround survey. Once the survey is completed, the service recipient can print out a paper copy of that survey and bring it in to their meeting with the doctor. or prescriber. So during that medication visit, the consumer and the prescriber together arrive at a shared decision about next steps in treatment. That shared decision is then documented within MyPSYCKES so that it can be a reference at future visits. Once the shared decision is made and documented, the service user might choose to return to the Decision Support Center to look up additional information, to talk to the peer and get additional support, or they could choose to leave. So that's really the model, that spending that time, that half an hour before every medication visit in the Decision Support Center generates that CommonGround report that then becomes a tool for dialogue between the consumer and the prescriber. So we've talked a little bit about how MyPSYCKES is used. I want to show people some screenshots of what the application actually looks like. Unfortunately today I won't have time to show you every section of MyPSYCKES, but I hope that this will at least give you a flavor of what it looks like. So this is the MyPSYCKES homepage. This is where people start. A couple of things that I'd like to draw your attention to. One is that we have developed a version in Spanish to support the needs of people who don't speak English as their primary language or feel more comfortable in Spanish. Both of our pilot sites have large monolingual Spanish populations, so they're great places to pilot this in a language other than English. Of course, the question that we get all the time is, what about other languages? And all we can say is that we'd love to get there, but we're going to start with Spanish. The other thing that I'd like to draw your attention to is this About Me button. This is a button that consumers can complete when they first start using MyPSYCKES. It includes some demographic information, and this is what we hope will help us in the future going forward be able to really tailor and customize MyPSYCKES to the unique needs of each individual. So as you can see here on this screen, there are three main components of MyPSYCKES: CommonGround, My Treatment Data, and the Learning Center. And we'll be talking about each of these. The reason that those buttons are so large is because MyPSYCKES is designed to be used on a computer touchscreen. So you don't need to be comfortable using a mouse or a keyboard. This can all be done by using the touchscreen on the computer. So this is just an example of our About Me page. As you can see, people can enter their name, their date of birth, gender, their language, their race, ethnicity. So first, I just want to show people what we mean by My Treatment Data. This is, again, a platform for sharing information with consumers. When we did our original focus groups with consumers and families back in 2006, people were really, really engaged and excited about the idea of being able to get all of their service history in one place. So that's what this does. MyPSYCKES is able to share with consumers all of their Medicaid treatment history. So anything that Medicaid has paid for up to 5 years. And this would include services and medications both for mental health as well as for non-mental health concerns. So by using MyPSYCKES, consumers are able to review, again, anything that Medicaid has paid for across treatment settings. So you can have all of your healthcare data in one place. This includes right now diagnoses, medications, services, any hospital or ER services. As I said, anything that Medicaid has paid for. This is a record, and you know, just speaking for myself, I know when I try and remember the different doctors I've been to and the different services I've had, it can be tough to remember what I was doing 5 years ago. So this, in a way, becomes an electronic memory for that. It captures all of that information and lets the individuals see it. So this is just part of what that report looks like. This is de-identified for demonstration purposes, but as you can see, it includes the information that we just discussed, including the medication and the services. Now this all comes from claims data. We get information from the New York State Department of Health. We have access to the claims data. So this is really billing information. Anything that any service provider has billed Medicaid for, we are able then to show the consumer. Right now, this is just a flat screen, so to speak, but we know that people are very interested in, for example, the ability to make comments about the services or the medications, to write a little note to themselves about their experiences. And so that is something that we hope in the future to be able to offer, that consumers would actually be able to make a little note next to a medication or a service provider to just sort of capture their experience with that. I want to briefly show you the Learning Center. This is a piece of the application that is still very much under development, and this is particularly an area where we're very grateful to Tony for helping us to convene a recipient advisory committee meeting that had just a wealth of suggestions and ideas about information that would be helpful to include. So we're working hard to try and get as much of that in as we can. But using the Learning Center, people are able to access both written material as well as videos about various dimensions of recovery, health resources for both mental health and physical health, tutorials, worksheets. I know there's a lot of interest out there in advanced directives, so we'd like to build in a section here for anyone who's interested in developing an advanced directive or a RAP plan. We could load those resources in here. We think that would be great, and that is something that we would like to do. Okay. So that's the My Treatment data and the Learning Center, but really the heart of MyPSYCKES is the CommonGround report, and so that's what we're going to spend some time reviewing right now. Okay. CommonGround is a tool that was developed by Dr. Pat Deegan as really a decision aid, an activation tool, a way to promote shared decision making between recipients and prescribers. So this is something that's done before medication visits. There are a number of different questions that help the consumer think about his or her treatment goals in general, overall. It prompts them to think about any changes in symptoms and functioning that they may have experienced since their last medication visit. Asks them whether or not they have specific concerns about the medications that they're taking. Helps them decide which specific goals for that day's appointment they would like to achieve, and also provides a way for consumers to track their progress over time. So this is not something that you do once and it vanishes. The advantage of doing it in an electronic format is that it lets consumers go back and see, you know, how are they doing today compared to where they were at the last appointment or 6 months ago. CommonGround has gotten a number of different awards. Most recently, in July 2010, AHRQ, the U.S. Agency for Healthcare Research and Quality, designated CommonGround as an innovation in quality improvement and in reducing disparities among mental health consumers. So sort of national recognition for this. And so we're very pleased to be able to bring this to New York State. Okay. So when the consumer logs on to CommonGround, and I should just mention here that the Learning Center resources are available to the consumers really anywhere. If you log on at the library or from home, you have access to those learning Center resources. You can also log on and view your treatment data from anywhere. Right now, the CommonGround report is really designed to be completed within a clinic setting. So when you come into the clinic, the peer welcomes you, helps you get settled in the Decision Support Center, and helps you log on so that you can begin your CommonGround report. So you have two options, and again, these are designed to be touchscreen. You can either get started with CommonGround, so the first time you come in, you would go there, or you can go right into the CommonGround section of the application. When you get started with CommonGround, there are three major tasks. One is to complete a power statement, another is to identify personal medicine, and then a third, which was added due to feedback from one of our early pilot sites, is to think about what your own individual unique early warning signs are. So the power statement really is designed to capture somebody's overall goals for recovery. What does this specific person want to be able to do with their life? And the goal there is really to help orient the prescriber and the consumer to those recovery goals. Not so much a focus on symptom reduction, but really what does Ms. Jones want to be able to do with her life, and how does she want to use medications to support that? Personal medicine is what we do, not what we take, and we'll be talking more about each of these. And then early warning signs are those initial signs, feelings, thoughts that maybe we might be entering a period where we need some additional supports. So let's talk about personal medicine first. Personal medicine are behaviors that we all, every single one of us, undertake because they help us feel better or make us feel more in tune with ourselves, more alive, more alert. They increase our sense of well-being. And again, Dr. Deegan really captures this as what we do, not what we take. So these are all the activities that people do. Some real-world examples of personal medicine that consumers have identified are taking care of pets, walking, doing yoga, other forms of exercise, making dinner for my family. So again, these are all activities that people can do every day that make them feel like themselves. Before we move on to power statements, and the reason that we really want to embed this into the CommonGround report is just as a reminder to people that their recovery journey is not just about their medications, right? That there are other things that they can do to help them along that road. Okay, so moving on to the power statement. Again, the purpose of the power statement is to really make sure that the prescriber understands what the consumer's recovery goals are. Not just taking medication for medication's sake, but what does somebody want to be able to do with their life, and how can the medication help support that? So here, for example, this is an actual power statement. Being a good mother and keeping a relationship with my daughter while she is in foster care is very important to me. I want you to work with me to find a medication that will allow me to stay alert and focused so I can control my temper, focus on being a good mom, and regain custody of my daughter. That makes it crystal clear to the prescriber what this particular consumer wants out of her life right now. Now, there are a number of worksheets that Dr. Deegan has developed that are available to individuals from within MyPSYCKES to help them think about their power statements in their personal medicine. So this is not something that people necessarily have to come up with all on their own unsupported. There are some great tools that people can use to help them think about this. And clearly, these can also evolve over time. People can change their power statements in personal medicine at any time. Okay. As I mentioned, the CommonGround report is really at the heart of MyPSYCKES. It includes an introduction about recovery, It's a multimedia piece, so there are opportunities to watch videos about recovery and personal medicine, and some of those videos were filmed right here in New York State. It walks people through a series of questions about their personal medicine and their early warning signs, as well as their medications. There's a series of questions about how someone is doing, so really about both symptoms and functioning, and then common concerns about medications. Finally, it finishes up with an opportunity for the consumer to identify specific goals for that day's appointment. And as I said, this all then gets summarized and printed out in a one-page report that people can take with them into their visit with the prescriber. In addition to having this configured as a touchscreen application, it's also configured so that people can either read or listen through headphones. So for people where there may be concerns about literacy or so on, we've really tried to make this accessible. So you can listen, and we are in the process of finalizing the Spanish voiceovers. So you, in addition to reading in Spanish, you are also able to listen in Spanish. As you listen, the buttons will light up as you move through the application. So we've heard some anecdotes about how even people who are relatively comfortable with reading like to listen, and people who aren't so comfortable with reading see this actually as an opportunity to practice their reading skills and see it as a way to sort of really promote their literacy. Okay. So this is the introduction to recovery. Again, just trying to remind consumers what some of the core principles of recovery are. Now this does show up every time you log on to the application, but if you feel like you don't need to spend a lot of time on these pages, you can just hit next at your own pace. Okay. Some information for consumers about what they will be seeing as they move through the application and how the CommonGround report will be used. Okay. An opportunity for people to watch a video about individuals describing their recovery. These are very, very popular. People really love hearing from and seeing other consumers. So this is a very popular section, and we are planning on filming new videos and continuing to add to this over time. We've tried to organize them thematically, so empowerment and treatment, self-expression. Sorry, it's a little bit off. I apologize. I was making last-minute edits to this right up until the time of today's presentation. But, you know, so a number of different themes: spirituality, young adults, sobriety, employment, trauma. So we think this is a great start. As I mentioned, they've been very well received, but we do expect to continue to build this out and add new topics over time. Okay. Then we go to the personal medicine screen, where we summarize, we show what the individual has previously identified as your personal medicine and give them the opportunity to comment on the extent to which they've been using their personal medicine. Then for each medication that they are taking, an opportunity for them to comment on how they're using that medication. And then a series of questions about how they're doing. So since my last appointment, my ability to keep up with my responsibilities and do things I need to do has been. And then you can select from a menu of options: poor, not so good, fair, good, excellent. I prefer not to answer at this time. Another how I'm doing question: since my last appointment, I heard voices or saw things that others didn't. All of the time, most of the time, some of the time, a little of the time, none of the time. I prefer not to answer. Now, one thing that we've added in to MyPSYCKES is the ability for consumers to say how concerned they are about a particular issue. So someone might be hearing voices, but they're friendly voices or they're voices that the consumer hears all the time and is not particularly worried about. So you can say to the doctor, are you concerned about this or not, by clicking on yes or no. So it really lets the consumer assess the degree to which they're concerned about a particular issue. So I'm not going to walk you through all of those questions. There's quite a number of them, but it's along those lines. It asks about sleep. It asks about racing thoughts. It asks about, you know, living situation, and so on. But people just use the touch screen to move through at their own pace. Then the next section is common concerns about using medicine. So the example question that we have up here, sometimes we, or people who are important to us, have beliefs that can create uncertainty about using mental health medicine. Examples might be certain religious beliefs or the belief that taking medicine is a crutch and that we should get well on our own. Do you have beliefs that make you feel concerned about taking mental health medicine? And then the consumer has the option of responding yes or no. And if they respond yes, then they're given a number of different potential concerns, and they can click on or touch whichever ones are relevant to them. So here's beliefs about mental health medicine. I think medicine is a crutch and a sign of weakness. I think I should be able to get well on my own. I don't believe I have a mental illness. My religious beliefs say I should not rely on medicine. My family or friends believe I should not use the medicine. I have other beliefs that make me unsure about using the medicine. So the MyPSYCKES user can sit down, and if this is something that they would like to say more about, that person can touch as many of these buttons as they feel are applicable, and then that all gets logged on their CommonGround health report. Once the consumer's navigated through the CommonGround health report, they can then think about the goals for their meeting with the prescriber, and again, it can be one or more of these. Discuss my concerns, ask my question, get information about my rights, get my meds changed, share my progress, get information, or another goal, and the consumer here could type it in, and if they needed help, the peer specialist would be available to help them there. They could type in their own individualized goal. Once they click Finish, this is an example of a CommonGround health report. So it logs each of the questions from the How I'm Doing section, their score on their first visit and the last visit, the previous visit, and then this visit, and whether or not this was a concern, and then it shows the trends over time. Now this is a somewhat earlier mock-up. We are doing lots of work thanks to the hard work of our pilot sites in giving us great feedback. So we are tinkering right now with the format and the layout of the health report to make sure it's as easy as possible for both the consumer and the prescriber to read. But this gives you an idea of what it would look like. Okay. Anything that the consumer has identified as a concern is highlighted in red. So you can see down here, the consumer has indicated that they have some questions or concerns about their motivation for taking medication. So that's flagged as red to kind of alert the prescriber that this is something the consumer would like to focus on. And if they had marked any of the items up above as of concern, those would also be highlighted in red. Just a few words about our current MyPSYCKES pilots. Our first pilot site is the Baltic Street Service Center, which is affiliated with the South Beach Psychiatric Center. We had been having conversations with them for quite some time, but in summer 2010, we really began serious implementation planning with the leadership there. In the fall of 2010, equipment was installed and a peer staffing plan was developed. And there we really had to get innovative, and what we were able to work out was a system of staffing the Decision Support Center with interns from Howie T. Harp. So we're, again, grateful to the wonderful collaboration that this project has enjoyed with Baltic Street AEH. They were key players in helping us to develop the staffing plan. Howie T. Harp that provided the interns, and that's been just a great experience, I think. Really, really happy at the way that that has worked out, and in fact we are getting ready to identify and train the next group of interns who will be starting in July. In January and February we did staff training and kickoff, and we actually had Melody Reefer, who is the training director for Dr. Deegan, come out and do training for the peer interns. So that was great. And they've been working hard ever since to roll this out. Our second pilot site, again, we're delighted to be working with the AIDS Center of Queens County, ACQC. In fall 2010, they were identified as the second pilot site. We began planning meetings with them over the course of the winter, and their equipment was also installed, and they configured their Decision Support Center. And then in the spring, we did staff training and the kickoff, and their go-live date was actually earlier this month. So again, very excited about how that is unfolding. Okay, so I'm finishing a little bit ahead of schedule, Tony. I hope that's okay, because that probably leaves us more time for questions.
Yeah, I'm here. I just I muted myself so I didn't accidentally step over what you were saying. Yeah, there was one thing that I would like you to address, please, is there is an assumption based on a couple of questions that have come in that this is only for Medicaid recipients.
Oh, yes, absolutely. Thank you for reminding me to clarify that. The only thing in MyPSYCKES that is specific to Medicaid recipients is the My Treatment data portion. So right now that is set up to show information from Medicaid claims data. So individuals with private insurance or Medicare, we don't have access to those data sets, so we wouldn't be able to show you the treatment history. But everything else, the Learning Center and particularly the CommonGround report, is available to individuals regardless of insurance status. And in fact, at both of our pilot sites, it's being used for Medicaid and non-Medicaid enrollees. So it's really designed to be used by everybody who walks in through the door for a medication visit.
Thanks. How is the record under the My Treatment data protected from being shared or viewed by unwanted persons?
Right. So we take confidentiality very seriously. Individuals are asked to provide consent for their Medicaid data to be viewable by the clinic in MyPSYCKES. So this is done only with the consent of the consumer, and there's a whole consent process that I didn't walk through in this webinar, but there is a whole consent process with a consent form that has been reviewed and approved by legal folks both at the Office of Mental Health as well as the Department of Health. And that consent is required for the My Treatment data to be loaded in. And there is a secure logon and password. So every PSYCKES consumer is given a unique user ID and password so that only they can log on. If they forget their password, the peer specialist is available to help them reset it. But it's controlled just the way any other protected information is protected through a secure server and a unique user ID and password for each individual. I hope that answered the question, but let me know if
yep,
I should.
Yep, people can send in their questions if that was not sufficient. But I think that was quite thorough. How recent is the Medicaid claims data in MyPSYCKES?
It's refreshed on a weekly basis. Now, because it's based on billing records, the timeliness of the information is based on the timeliness of the service provider's billing. So what we do find is that medication data is quite fresh because the pharmacies bill right away. It's an electronic kind of exchange. So the medication information is usually, within weeks. The other data, so the services, the ER and hospital, again, it depends on how well people bill, how timely they are about getting their claims into Medicaid. But once it's in, as I said, it's then refreshed on a weekly basis.
Okay. If an individual feels uncomfortable for whatever reason utilizing the program, is it optional, or would the individual continue to receive the treatment without using MyPSYCKES tools?
Sure. So this is a really important conversation to have with the consumers. They are not forced to answer any of the questions. But what Dr. Deegan has shared with us is that this works best when it's really seen as the way the clinic operates. That this is just the way we think we can best help people is to embed this tool so that the prescribers can do their best to really help the consumers meet their goals. So people might take a little while to feel comfortable with it or to warm up to it, and that's in part why the peer specialists are so important in the Decision Support Center, to really help people feel comfortable using it. In many places, the therapists also help people to sort of think through and identify what their concerns are. But ultimately, clinics deciding to implement MyPSYCKES are saying, we think that this is the best way to work with people to help support their recovery, and so we're going to do everything we can to support them in using this tool.
Excellent. The next question is the half hour with the peer specialist working on the CommonGround report, is that billable?
You've identified really the piece that we are struggling with right now, and that is how to make this work from a financial point of view. So right now in clinics, my understanding, and Tony, feel free to jump in here.
Okay.
In clinics, on-site peer services are not billable. So our pilot sites have gotten creative in how they are supporting this work. As I mentioned, at Baltic Street, we've been fortunate enough to be working with the interns from Howie T. Park. ACQC already had a peer specialist on staff that was funded through other resources, so they already had a peer staff on site that they could dedicate to this project. But that is something that we are very mindful of, and I think John Allen is hopeful that we will someday get there in terms of having peer services be a billable service. But that is also clearly a challenge, particularly for clinics. I know that there are other programs, other services out there that may have peers on staff already and may not face that same kind of challenge.
Yeah, my understanding, and I could be wrong, but my understanding is that in the Part 599, in the part of the clinic restructuring, that there is a service in there called outreach, or outreach and engagement, and that that is a mandated service, but that we are waiting for approval, I think, to our Medicaid state plan. So we haven't received federal approval on that yet, but that would be, I think that might be a mechanism to help with this.
Right, and I think there the concern was just there was some thinking or you know, there had been some indication that those outreach and engagement services might need to be provided off-site. But I think you're right, Tony, that we're definitely in an evolving environment, and but people should know that we are very aware of this. John Allen is very aware of this. Commissioner Hogan is very supportive. I'll just say, you know, he's very supportive of MyPSYCKES. In fact, he was at a peer conference yesterday down in the city and immediately emailed us to say, you know, this is just getting me thinking about how we can support a wider implementation. So there is a lot of support for this conceptually, and it's just a matter of trying to figure out how to really make it work from a fiscal point of view.
Yes, I was at that peer, it was a peer specialist conference down in New York City yesterday. They had like over 300 people. Pat Deegan was there, and she was speaking around about peer specialists, but the MyPSYCKES was salt and pepper throughout the day. It kept coming up. So by Pat, by me, by other people. So it was definitely on the minds of folks. So when do you think it will be ready? You know, apropos, when do you think it would be ready for a statewide rollout?
You know, I think we are learning so much from our pilot sites, and it's been really great. They have just been wonderful collaborators and partners with us. So what we, you know, I don't want to commit to any firm timeframes because I don't want anybody to be disappointed. We had actually in the fall asked mental health clinics here in New York City that were working with us on another quality improvement project whether any of them would be interested in implementing MyPSYCKES, and that's how ACQC joined us. They were the ones who raised their hands. Once we've had an opportunity to kind of work through with our pilots to make change, one of the things that we'd like to do potentially this fall is to really take another hard look at the application, build in any changes or tweaks or additions that have been suggested by people who are really using it. We by no means think it's perfect. We think it's pretty good. The CommonGround report is really what Dr. Deegan is using elsewhere, but even she agrees that there probably are ways to make it better, and she is working with us on that. So we'd like to have the opportunity to make those changes, and then you know, we'd love to talk to other people who might be interested in piloting this. I know there are a couple of providers that have reached out to John and Tony to express their interest. So even though I can't give a firm time frame right now, I would really encourage anyone who's on the line right now and might be potentially interested in implementing this, or if you'd like to pass this along to somebody, please encourage them to get in touch with us and let us know, because the more interest we have from the community, the better, and the easier it is for us then to go to leadership and say, you know what, this is really resonating and there's a lot of interest, and let's figure out how we can make it happen. So please do let us know. I would be happy to talk more offline with anybody who's interested, anybody who has, you know, sort of specific questions. Would love to hear your thoughts about it.
What would be the best way for, because there is some interest in the questions here, where would people go to contact you? What would be the best way to do that?
I'm sorry, Tony, you faded out a little bit. What would be the best way for people to do what?
To contact you if they were interested.
To contact you. Mm-hmm. I will give you my email address if that's the best way. It's Edith, E-D-I-T-H, .Keeley, K-E-A-L-E-Y, so Edith.Keeley at omh.ny.gov, G-O-V.
Okay, and I've just sent her email address out to the audience.
That's fine.
And in the interest of you know, practicing a no wrong door policy, if you don't mind, people will be getting automated emails from me over the next couple of days, you know, through the GoToWebinar software. So if you respond to that as an interested site, you can please feel free to do that if that's easier for you, and I can just pass that on to Edith. So
absolutely.
And we will also have people who are listening to this in an archived form, down the road. They'll listen to the recording. So for those folks, when that happens, you can also again just send that off to me or send that off to Edith, and we'll make sure that she gets it. Okay, thank you.
As Tony said, no wrong door.
Did the pilot agencies express any interest in working with their existing client database software vendors to link up with MyPSYCKES in any way, or is it a vision on the OMH side?
Sure. I think there is a lot of interest in integrating this. I mean, clearly, particularly for sort of busy clinicians, logging into one portal rather than multiple portals obviously is the preferred way to go. So there is a lot of interest in that. I think we're still sort of at the conceptual stages. South Beach does have an electronic medical record, and I'm sorry to say, I'm not sure if ACQC does. I can't remember exactly. I'm thinking no, but I could be wrong. So there is a lot of interest, and that does come up frequently. What I can share with you is that we're actually working on another initiative, and some hospitals have been able to tailor their EMRs to capture certain aspects of our project. So it's not a full integration, but certainly there is a lot of interest in getting all of these electronic portals to talk to each other, particularly with the RIOs. So I think that's something that we're very open to and would love to explore.
Okay, so what I've learned about working in state government is, if you want to know how something works, follow the money. So I've got some questions around money. How are programs funding the purchase of needed equipment, and what are the costs associated with this project?
Right. So there are two sources of costs. One is infrastructure, so having the computers and touch screens and the kiosks in the Decision Support Center. And that's sort of essentially a one-time thing. You might need to replace the computers, you might need to replace the printers, every several years, but there are the infrastructure costs, and then there are the ongoing staffing needs. So there is a staffing model for the peer specialists within the Decision Support Centers based on how many prescribers you have at any given time and what the appointment duration is. So it's all keyed around kind of the flow of clients into the clinic. And so those are the two major sources of costs. So the computers and the kiosks for the Decision Support Center, and then the staffing. Our two pilot sites have used different approaches. So at South Beach, they were able to get state funds to purchase the computers. And as I said, in terms of the peer specialists, the staff for the Decision Support Center, they're working with Howie T. Harp and using interns from the Howie T. Harp intern program. At ACQC, they had grant funds available, and so they decided to use those. They received approval from the funder to use a portion of those funds for the MyPSYCKES project. So that's how they're doing it right now. As I said, right now, it's not a Medicaid billable service, but certainly we would advocate for that, and it's something that we would love to see.
Okay, next question is, when will this be generally available to clinics? I think you kind of talked about that a little bit, and do you anticipate that there'll be any support for the infrastructure needed to implement it? So for clinics that don't already have a peer, for example, plus the computers and internet access.
Yeah. Decisions about funding are somewhat above my pay grade. There are always going to be clinics that see this as, a good fit with their culture and want to do it because they see it as something that is for them the right thing to do, and whether they can find either internal resources or grant funding or some other sources. certainly for anything sort of statewide, I think we do need to figure out a way to support it, but we haven't figured that out yet.
One thing I can say is that although we don't have, to the best of my knowledge, we don't have touchscreen computers, but all of our facilities do have computers that typically get refreshed about once a year or so, and our office runs a program called Recycling for Recovery, where we distribute those surplus computers to programs that are interested, that would like to participate in that. There are some strings attached, but they're pretty mild. So they're free computers. You also get the monitor and everything, and then but we do ask people to join us for webinars like this, to join our listserv, and to make it available for email and things like that for families and for peers. So that's basically what we're asking. It's just a good faith effort that you would do that. Last year, actually just this last refresh was in March, so the next one probably won't be until March, but we gave out, I think it was 218 computers throughout the state. So that is something that's available that may be helpful for folks. But that's all I'm aware of right now. And if you're interested in that program, just send me an email. Like I say, you'll be getting emails from me automatically over the next couple days, but not too bad, so I'm not spamming you. Will the implementation and installation of MyPSYCKES equipment and program costly? I'm sorry, I'm going to have to skip that question. It's not a complete sentence. Does OMH envision MyPSYCKES eventually becoming a requirement in any program types, or will it remain optional?
I have not heard anybody talking about it as a requirement. I think it's a little early given that we're still in the pilot phase. I think we'd love to speak to people who are interested in this and who think that it would be a good fit for them, but that's as far as we've gotten.
And what has been the feedback from staff and consumers at the pilot sites? Is there any data on changes in outcomes or prescribing practices?
We are definitely very interested in that, and we do have an evaluation plan, and that is going to be a major focus of our activities kind of late summer, early fall, both in terms of sort of qualitative work in doing focus groups and interviews with staff and consumers, as well as some quantitative work in looking at patterns of use and how many consumers actually are using CommonGround on a regular basis, and can we associate that with any changes in service utilization or outcomes. So that is a question that we are extremely, or a set of questions really, that we are extremely interested in answering. I can say anecdotally, just from kind of, hearing from the people who are using it now, I think overall people like it. People like it. Anytime change can be hard, and this can be a big change for some people. But I think overall, people once they start using it, they really start to appreciate the value and just the whole concept of language like personal medicine and power statements. That's something that really the whole staff can embrace. And so the therapists are talking about it with their, with the consumers, and the psychiatrists. So it really is a great way to kind of get everybody on the same page and sort of speaking the same language. And I think that has been well received at the clinics.
Are there ongoing software license costs?
No. No, this is something, so OMH licensed, we have a permanent irrevocable license to the CommonGround survey that's in the application. And so the MyPSYCKES application is made available to clinics right now free of charge. There are no costs associated with that. It's just the infrastructure and the staffing.
Are the medical records printable? The reason the person is asking is that this may be helpful for people who are applying for benefits.
Are they printable? Is that the question?
Yes.
Yes. Yes, they are. Yes.
Cool. One person is more of a statement. This is a fabulous application for the health homes, so hopefully you can solve the fiscal viability question and make it available statewide soon. That does bring up another question, though. Do you know if, I mean, will the Affordable Care Act or the Medicaid redesign team, will any of that affect the MyPSYCKES initiative?
That is one aspect that has come up in conversation. Is there a way to engage the behavioral health organizations around this, the medical homes? We think it is a potentially great tool for them to use. So there is interest in exploring that, but we are still at the early phases.
And how does this fit into PROS at all? Do you envision it fitting into PROS?
I've been saying ever since we started that we needed to be talking to the PROS programs. So I'm a big fan of trying to figure out a way to give this a whirl in one or more PROS programs. I think it would be a great partnership. So if there are any PROS programs on the line who might be interested in this, I hope you'll get in touch with me.
Yeah, it seems like it's a pretty natural fit. The
yes.
philosophies seem to be very similar, so that's excellent. We do have someone in New Jersey who is looking for some help in New Jersey around something like this, so they can touch base with either you or I.
Sure.
Let's see. I'm looking at just some other. It doesn't look like we have any other questions, and all of my other questions have been answered. So let me just, if people have any other questions, just send them in. But right now, I think we'll start to wrap up. So I just want to say that in the consumer movement, medication can be a very polarizing issue. It has really divided the people in the movement. Some people feel like medication can be helpful. Some people have had very, very bad experiences with medication or have been forced to take medication, which has created a resentment and a reaction against medication. So for some people it's helpful, for some people it was not. I think one of the things that I like about the MyPSYCKES is that it's a very reasonable way to approach this medication sort of polarity. When we first enter into the mental health system, it's sort of like losing your virginity. You never forget the first time, and those first messages that come to you generally tend to determine the trajectory of your recovery path. So most of us who've been in here for a while, it was thought that you were not going to get better if you had mental illness, and that you were probably likely to get worse. But now we know that that's not true. We know that people do get better, sometimes with medication and sometimes with not medication. But the important thing is that this is a really great way to engage people, whereas in the past, promoting a medical approach or a medication approach was really one of the first steps. For a lot of people, it was one of the first steps to becoming a professional patient, and languish and get stuck in the system for a long time. As you can see in this model and in this method and this approach, is that no, that's an ancillary sort of situation. Even though you're there for medication, it's looking at the whole person, as a parent, as an employee, as a spiritual person. So it's incorporating all of that and what's important to the person, and that the medication is secondary just to support what that person wants to be and wants to do. And that's a profound shift in the axis of how we've approached mental health treatment. So this is a very revolutionary thing. I think it's very good. I think it's very helpful, and I think it's going to be great for a lot of people. We do have a couple other questions. Before I get to that, though, MyPSYCKES was an offshoot of the PSYCKES initiative. Do you mind just talking a little bit about the PSYCKES and the context of polypharmacy? Because I didn't hear you speak much about that.
Sure, and watch out what you ask for, Tony, because I could talk for a long time about PSYCKES. for the purpose of this presentation, I didn't want to get too distracted, but thank you for the opportunity just to comment briefly on that. This all started actually back in sort of 1997 when Dr. Molly Finnerty was actually a resident here at Columbia and encountered a situation with a client that just really brought home the importance of having access to historical information. And one thing that happens is that these large administrative databases, that are really built for non-clinical purposes like billing, end up containing all kinds of really important information that would be really helpful to clinicians, like which medications have been used in the past and where have people gotten services, things that are just really helpful to know and to be able to take into account when you're trying to think about what will be most helpful for somebody. So she started a project with OMH to develop a portal to use administrative data like billing records, like pharmacy databases, to share that with clinicians in a way that would be helpful and not overwhelming. Some of you on the line may have had the experience of getting, records where it's just 50 pages of data that is really hard to sort of process and understand. So PSYCKES, which stands for the Psychiatric Services and Clinical Knowledge Enhancement System, is a platform that was developed to take these large administrative databases and aggregate the information in ways that would be helpful both for clinicians as well as for quality improvement. So being able to look at patterns and trends over time in terms of quality concerns and what's going on for medications and service utilization. So we first developed a version that was used in our state inpatient system that used OMH databases, and that was a very successful implementation. We were actually able to reduce the use of polypharmacy, antipsychotic polypharmacy in particular, in our state hospitals. And so based on the success of that initiative, we were able to get funding to develop a version that used Medicaid data. So as the Office of Mental Health, we have a particular responsibility towards the public mental health system. And so using Medicaid data, which we obtained through a memorandum of understanding with the Department of Health, we developed PSYCKES Medicaid, and we had a scientific advisory committee help us think about which quality concerns we might want to target first. They came up with a list of 70 or 80. So what we started with, as Tony mentioned, were polypharmacy and also cardiometabolic risk. So those were the first two quality concerns that were put into PSYCKES, and we worked with over 330 clinics around the state to help them develop quality improvement projects focused on reducing either polypharmacy or cardiometabolic risk, and using PSYCKES both to help them identify clients who had this quality concern, to take a look at their, at their treatment history, to think about what other options might be appropriate, and also to look at variation so that they could understand the aggregate data, the trends and the patterns over time. So that's been moving.
Just if you don't mind, for people who may not know what polypharmacy is, could you just explain that for real quick? Thanks. Sorry.
Absolutely. No, thank you very much. Polypharmacy, when we talk about polypharmacy, what we really mean are using more than one medication to target the same thing. So using more than one antidepressant within the same subclass, or using more than one antipsychotic, or using a lot of psychotropic medications just in general. So there are times when that's clinically appropriate and that's what the client needs and agrees will benefit them. But then there are other times when, maybe this is an opportunity to think about whether an individual really needs all of those medications. So what PSYCKES does is it helps the clinics who are doing quality improvement really think about who could benefit from a change in medication, who maybe is at a point where they don't need all of the medications, because when you're using a lot of medications, that increases the side effects, it increases the difficulty of actually taking the medication in a safe way. So there are risks to taking multiple psychotropic medications, and this is a way of helping clinics, prescribers and consumers really have a good conversation about the risks and benefits, and is there an opportunity to try and lower the amount of medication. So that project has been underway. We have seen significant reductions in both polypharmacy and the use of higher risk antipsychotics among people who already have health problems like diabetes, so that's the Cardiometabolic Risk Project. We have seen significant reductions in that statewide, so we're very pleased. And this summer, or earlier this year, we actually added in some additional quality indicators, looking at high dose, looking at prescribing issues among children and adolescents, and we're getting ready to add in some additional indicators primarily around sort of hospitalization. So PSYCKES Medicaid continues to grow and evolve, and again, we are very grateful to our Stakeholder Advisory Committee, which includes representatives from consumer and family organizations as well as provider organizations to help us think about how we can really make this a tool that helps providers and consumers make evidence-based decisions about care.
Thank you. Any last words or any last thoughts?
Just to thank you for the opportunity to bring MyPSYCKES to this wider audience. It's a program that we're really excited about. This is not something that we have embarked on lightly. It's something that we've really put a lot of thought into over many years with the assistance of many, many people around the state. And again, I want to thank Tony and John for all of their work, and it's something that we're in for the long haul, and we'd really love to see a way to help this spread and grow, because it's a program that we really believe can really make a difference and really help people, both consumers and clinicians, as they work together to provide care that is person-centered and high quality.
Excellent. Thank you very much. Thank you so much, Edith, for being here today and presenting.
You're so welcome, Tony.
I want to thank everyone also for attending today. Just a reminder that we will, when I close this out, there will be a window that opens up on your computer screen that has a short survey on there, so if you could just please fill that out. And that in July, we will not be having one of our monthly webinars in July. Our next monthly webinar will be August 17th, and I'm not sure what the topic on that is going to be yet, but I think we're leaning towards spirituality and having a panel discussion from a number of different and diverse group people to present the role of spirituality in recovery. So we go from a scientific medical approach, and now we're going into a mystical, not necessarily scientific approach. So we're trying to cover all the bases here in these things. So hopefully we'll see you in August. And again, thanks everyone for attending today. Thank you again, Edith.
Thank you, Tony. Take care, everyone.